The list speaker in this session is Professor Ahmad Zakaria. He is a well-known figure in the field of maternal-fetal medicine, but fortunately, he will address us a very common gynecological problem, dysmenorrhea. He will address us about update in medical management of dysmenorrhea.
Okay, thank you very much for the kind introduction. This is a sponsored talk. I'm going to be talking about the role of progesterone in the treatment of dysmenorrhea. And actually what I want to highlight is what I'm going to cover in this session. I'm going to talk about the types and causes of dysmenorrhea, the lines of treatment available, the physiological changes that happen in the endometrium, and what happens actually differently in cases of endometriosis. What's the role of the Enogest as a new progesterone therapy for dysmenorrhea and endometriosis? Do we carry side effects with long-term therapy with the Enogest? And what are we going to do about the minor drawbacks and side effects when you start a progesterone therapy like the Enogest? And when we look into endometriosis, it's a very common condition reported to be between 34% to 94% in adolescents and young women. Dysmenorrhea is divided into two main categories: the primary type, where you don't find an underlying pathology, and the secondary type, where you have generally other organic causes as endometriosis, adenomyosis, uterine myomas. And the primary cause of dysmenorrhea is thought to be excessive secretion of prostaglandins from the abnormal endometrial cells during menstruation, which results in endometrial contractions and ischemia. And that's actually the cause of pain. And when you look into the changes that happen in the endometrium, we go through a cycle of early proliferative, and then we go into a secretory phase when you have the progesterone, and then you have the progesterone effect of the endometrium. And as we all know, it's the progesterone effect that's actually quite protective on the endometrium against cancers, against the development of other pathologies. And when we look into lines of treatment of therapy for dysmenorrhea, we need to understand or put to ourselves a rationale. And it was a good start to have Khalid Ismail in the first lecture talking about PMS, and then following that up with dysmenorrhea. The aim of treatment is mainly to suppress ovulation if you can, and suppress the abnormal endometrial proliferation, which is associated with the pain. This can include a series of medications. If you want to control pain, then you're looking into non-steroidal anti-inflammatory drugs, working mainly on prostaglandins. As well, we can actually look into the hormonal therapy to suppress ovulation or suppress the endometrial cells. Either you give low-dose estrogen progesterone pills, or you use the Mirena-releasing intracontraceptive device, or use progesterone-only pills, including the Enogest. And when you look into that rationale, you need to understand what happens in endometriosis. You need to define and make sure that you actually diagnose the endometriosis, particularly if you can see it obviously during the scan. But you have to know as well that if you can't see the endometriosis, then a significant proportion of young adolescents will have endometriosis, even if you can't see it on ultrasound, and you will find it more while you're doing laparoscopy. And what you need to understand is the difference between what happens in the normal endometrium compared to the endometriotic lesions, because luckily enough, in the normal ectopic endometrium, the estrogen in the proliferative phase of the cycle does actually work on its estrogen receptors to increase the production and the description of the progesterone receptors. So estrogen is actually working to increase the progesterone response, which will happen after ovulation. The progesterone actually works by reducing the 17-beta hydrogenase enzyme, so it actually breaks down the estrogen that you have from estradiol to estrone, which is a weaker estrogen compared to the estradiol. This is actually quite protective in its action. So the estrogen and progesterone work together to reduce the strong proliferative effect of estrogen in the normal cycles, and the progesterone then down-regulates that strong effect of estrogen, and as well the estrogen that has already produced good progesterone receptors would work together to have an equivalent in the balance, so that they work together on a protective level. In endometriosis, actually, the contrary happens, because, as I mentioned, about 60 to 70% of adolescents having primary dysmenorrhea would have endometriosis, and the endometriotic implants, actually, there is reduced estrogen receptor beta activity, estrogen receptor alpha activity, and the estrogen receptor beta activity is remarkably upregulated. And when this happens, it leads to loss of the progesterone protective effect on the endometrial cells. So in endometriotic lesions, there's actually a kind of resistance to the inherent progesterone that is there. Let's compare what we're going to do about surgery. Should we do surgery in all the cases of endometriosis? And we had actually a couple of sessions on the last two conferences actually addressing that specific point. The meta-analysis have now showed that the reports that the post-operative loss of ovarian reserve approaches 34%, including that done by laparoscopic approach. However, should we actually give nothing? As well, if you don't give any treatment and you go on a conservative approach, you still lose about 25% of your antimolecular of your AMH levels in the cycle. What about if you give a hormonal kind of treatment? Well, the rate of the drop of AMH and the rate of the drop of anterior follicular count is actually reduced. But this actually works more on anterior follicular count in comparison to AMH. When we look into what we're addressing today, we're addressing a form of progesterone that has been there for quite some time. The Unigest is a 19-norethistérone derivative. It's a synthetic form of progesterone, which works highly selectively on progesterone receptors. It exerts an anti-ovulatory and mild hypoestrogenic effect. As well, it shows an anti-androgen effect. But luckily enough, it lacks the glucocorticoid activity, which is present in some of the other forms of the hormone. And this actually gives a protective effect against its incidence of thrombosis. And when we look into the impact of Unigest on dysmenorrhea, well, it actually worked quite well on all types of dysmenorrhea, if you can see here. And as well, it worked more or less more effectively on the primary forms of dysmenorrhea in comparison to the secondary forms. And that's actually quite understandable because of the pathology that can be there in cases of secondary dysmenorrhea. Well, should we use the full dose or can we use a smaller dose of the Unigest? And let's look into the efficacy. Well, the results suggest that even using a 1 milligram dose of the Unigest as a treatment option has a low risk of thrombosis. It exerts a suppression effect on the estrogen production, and it reduces pelvic pain in a significant proportion of the patients. And the reason why we mentioned that, although this dose does not suppress ovulation, but it still can be effective in suppressing pain. Well, the full dose or the standard dose of the tablet you have per day is about 2 milligram. And even using the 2 milligram level of the Unigest, which is the standard dose we use, is actually inhibiting to some extent on the ovulation and the gonadotrophic hormones, but still they maintain the estrogen level between 30 to 60 picogram per milliliter. So this maintenance of the estrogen level is actually quite important because it maintains your bones, it maintains the cholesterol levels, and it can be quite protective to the patient. As well, it has the anti-androgenic activity, which with no other relevant no other irrelevant receptor activity. So it will give you that benefit in addition to having the anti-androgen activity that you need. Let's look into the effect of the Unigest on the size of endometriomas. So the medical therapy that you're using was actually quite effective in reducing the size of endometriomas by even up to about 70% reduction in the size. And this has just been published in a recent study in the year 2020. So just last year. Let's compare it to its effect on ovarian reserve. In another present study that has been published in 2019, it was found that the medical therapy does actually increase the anterior follicular count, and it maintains the level of AMH. So it maintains the level of anti-Mullerian hormone, but it increases the anterior follicular count. And the reason for that is mainly because the protective effect of the progesterone is mainly on the larger cohort of follicles. So the maintenance effect of the therapy is actually quite protective in maintaining ovarian reserve. What about the effect of the therapy, and should we actually consider it as an adjuvant treatment following surgical interventions? Well, this was a really nice study. It has been published quite some time now, which showed that there is a significant reduction in the incidence of post-operative recurrence, which is under 1% in the therapy group, compared to about 29% recurrence rate in the placebo group, which did not receive a treatment. So as well, the therapy would actually improve your surgical outcomes if you've already considered surgery by reducing your post-operative recurrence. What about using that prior to IVF cycles in patients with proven endometriosis? Well, there has been a benefit. There is as you can see here in the pink columns in comparison to the blue columns where we used gynoprogest. Well, there has been a higher rate of cumulative implantation, a higher rate of clinical pregnancy, and a higher rate of live birth rate. And I guess it's actually quite evident, because if we understand the rationale and the theory why we're having endometriosis, the impact that endometriosis causes by the inflammatory effect that happens due to the loss of progesterone activity, then if you suppress the endometriotic foci that you already know that it exists in this patient prior to starting your IVF cycles for a short course, then you're probably improving the outcome of your IVF cycles. What about its effect on deep endometriosis? And we have seen a couple of very nice lectures on deep endometriosis today. Well, in intestinal endometriosis, the use of long-term 2 milligram Dynogest has actually improved the quality of life on those patients and the risk of chronic pelvic pain to a proportion that helps relieve the symptoms caused by deep intestinal endometriosis. Let's compare it to the other modalities of therapy. So let's compare Dynogest to gonadotropin-releasing hormones analogs. Well, both of them were quite effective in reducing pain, but Dynogest, because it does not suppress the production of estrogen significantly compared to the gonadotropin-releasing hormone analogs, reduced the incidence of having hot flushes, and as well, it maintained the bone marrow matrix, because it does not have the suppressive effect on the bone density in comparison to using gonadotropin-releasing hormone analogs that have a significant reduction on the estrogen production. Let's look into its safety. So bone marrow density, the effect of Dynogest, because that is also a concern, particularly for adolescent patients. Does it actually harm the bones this much? Well, the reduction of the bone marrow density is only 1.2%. And what does pregnancy cause? Pregnancy alone does actually suppress 5% of the bone marrow density. So 1% in adolescent patients that are suffering with severe dysmenorrhea, I guess, is quite acceptable. What about bleeding? Well, that's actually one of the issues that we have with the patients, and that's actually the benefit of counseling and telling the patients the solutions that we have. And you always have to warn the patients that she might have an initial bleeding, which typically lasts for about 8 to 10 days at the start of therapy. Most of the patients will end up having their regular 28-day cycles. Bleeding is usually in the form of spotting. And what we do is that if you find that the Dynogest has actually been quite suppressive on the endometrium, and you have quite a thin endometrium that's under 5 millimeters, then maybe you would then consider a short course of break, maybe 5 to 7 days break of therapy, or giving them a small dose of maybe a week of oral estrogen therapy to help improve the thin endometrium that's actually causing the spotting. What about its efficacy on the breast and other psychological issues that can happen? Well, there is a reduction in the size of the mammary gland with no increase in the risk of breast cancer, and it seems to be quite protective in the aspect of breast cancer. As well, depressed mood can be observed with Dynogest 2 milligram, as well as other hormonal therapies, and it happens in a small proportion of about 10% of patients. And maybe in those patients, we might consider a short break, maybe of a week or so during the cycle to help reduce that side effect. What about its risk? Dynogest in comparison to oral contraceptive pills in endometriosis. Well, a recent Cochrane review concluded that based on limited evidence, that there is lower benefit from using oral contraceptive pills, or no proven benefit of using oral contraceptive pills to treat pelvic endometriosis. And the rationale behind that was that oral contraceptive pills do increase the levels of estrogen in comparison even to the normal physiology. And if you're increasing the estrogen, again, in a patient who is actually progesterone resistant, then you're not actually gaining much. But if you use a progesterone preparation that will work directly on the progesterone receptor from the start, then this rationale becomes more understandable and more appreciated. So let me summarize what we've discussed. Dynogest is safe and effective in treatment of dysmenorrhea, whether it's primary or secondary, and this has been proven and published. Dynogest is safe to use in adolescents with minor side effects, and its impact on bone marrow density is only about 1% reduction, which can be quite understandable and accepted. And we usually encourage those patients as well to have a regular kind of physical therapy and physical exercise to help improve the bone marrow density. As well, Dynogest exerts its effect mainly on endometrial cells through progesterone receptors, so it's quite safe and effective in reducing cancers. As well, it is safe on long-term therapy with a significant reduction in the symptoms. It does not increase the risk of thrombosis because it lacks the glucocorticoid activity in addition to having a weak action as an anti-androgen, so it can help the androgenic manifestations. I thank you very much for your attention, and I'm open to any questions.
Dr. Ahmad, yes, you say that the diagnosis can be is not contraindicated with cases of cancer breast. Can you describe this drug?
No. I did not say it's not contraindicated cancer breast. I say it's not increasing the risk of cancer breast.
My question.
No, but all patients who have cancer breast, they always have the screening for receptor activity. So if they have estrogen or progesterone receptors, then I definitely cannot give them any form of hormonal therapy. So I'm not going to give it to a cancer patient. But I'm saying that it does not increase the risk of cancer breast, and it can be protective in that aspect.
Thank you.
Okay. Thank you very much, Mr. Chairman.
Excuse me. You said that progesterone can use and relieve the hot flashes when the gonadotropin is released. So it is, we can say that it's a banishment of hot flash or no?
No, I did not say that it reduces hot flushes. If you compare the progesterone preparation, you're not reducing the estrogen content of the patient significantly. You have a baseline estrogen of about 30 to 60 milligrams. If you have that, then the reduction of the gonadotropin releasing hormone is not significant, so you maintain your levels of FSH to a reasonable level. So you don't get the peaks of FSH that will cause the hot flushes. But when you use the gonadotropin hormone antagonists, what you do, you actually suppress significantly the estrogen production. And when this happens, you can sometimes get peaks of FSH, and then you will have hot flushes. So it's not a treatment for hot flushes, but using the therapy, you do not get hot flushes as a common side effect.
The pairing between combined oral contraceptive pills and dysmenorrhea. According to most of the guidelines, combined oral contraceptive pills is first line of treatment. And you can, the last French guidelines for management of endometriosis associated pain, combined oral contraceptive pills. As regards the Cochrane systematic review, there is no conclusive conclusion for this.
I totally appreciate that, but we always started considering OCP as a line of therapy for endometriosis in the past, until the impact of using progesterone alone with the high proportion of side effects. And I guess the modification that happened is because when we used progesterone alone in the past, we used to have a very high volume of side effects. There was a modification in the preparation and the dosage of the progesterone to help reduce that side effects. And in comparison, using the OCP alone or using a more specific drug seemed to be more protective. We definitely face patients where the progesterone do carry a significant proportion of side effects, and you cannot continue on progesterone, and you have to actually shift again to the OCP. I totally appreciate that. The Cochrane review and the rationale behind using the OCP was different. But still, OCP is one of the lines. I cannot actually deny that, and I cannot actually take it out of the prescription. But what we're saying is we're just putting a comparison between it, giving no treatment, doing surgery, giving just the non-steroidals. And by that, we're not actually giving much of a protective effect on the size of the endometriomas or on the ovarian reserve, or giving OCP in comparison to the dysmenorrhea or the progesterone preparations. The problem we had in the past was the very androgenic progesterones we had. And now if you're using a less androgenic progesterone, which lacks the glucocorticoid efficacy or effect of that form of androgen, then actually it will help improve your side effects. It will reduce the patient's symptoms, but definitely we suffer with any patient taking progesterone with some side effects, and that's why we're trying to modify the preparation. That's why we said sometimes if the patient has just pain, you might start on 1 milligram, particularly in adolescents. If you can go to 2 milligrams, then yes, it will improve your size of endometriomas, but some patients will not tolerate the 2 milligrams, even with the newer preparation. So we totally appreciate that point.
Effect on the anti-follicle count and the AMH. You mentioned, I am astonished how it increased the anti-follicle count and has no effect on the AMH.
No, it did not reduce the AMH. It did not change the AMH.
You increased the anti-follicle count.
Yes, that was actually quite PDF بس عشان مش فاتحة لي من الباوربوينت. It did not reduce the AMH because the AMH is mainly produced by the small size follicles, the very small ones below the 2-3 millimeter size. The follicles between 3 to 10 millimeters, the Dino just does not work on them. Sorry, the Dino just works on them, but the ones below 3 millimeters, the Dino just does not work on them. So the AMH level remains the same, but at least it does not drop, or it's in a kind of maintained. But the follicles that are actually going into the cohort all the time, these are the ones which have a protective effect using the progesterone preparation. I can show it here in that slide. Any other question? So as I mentioned here, Professor Nashar, so it mainly, the AMH is mainly produced by the small size ones, the ones under 6 millimeters. So it does not actually work on those, but it works on the slightly larger size follicles between 6 to 10. Any other questions? Okay, we'll have a break and we'll be back for the next session at 1. Thank you.
Thank you, Ahmed.